right, welcome back to Conversations with AcroPsych, where we create educational, inspiring dialogue around psychiatry and addiction. I'm your host, Dr. Matt Campbell, and today I'm joined by the one and only Dr. Anna Huh. Anna, welcome.
Hi, Matt. Thanks for having me.
Dr. Anna Huh completed medical school at Dartmouth and a 4-year psychiatry residency at Albert Einstein School of Medicine, Montefiore, in the Bronx, New York, which is actually where we met. After that, she went on to complete a community psychiatry fellowship at Columbia, where she works with providing really high-quality psychiatric care, people with serious, complex behavioral health needs, and multiple community service systems. So really awesome to have you. Do you mind just starting and telling people a little bit about what community psychiatry is and how that's different than maybe myself as a psychiatrist or other psychiatrists?
Community psychiatry is also called public psychiatry, and it basically is psychiatry that serves the specific population of people who are accessing public services. So, for example, Medicare and Medicaid and all of the other types of benefits that are given socially, Social Security, public assistance, and other things like this. They tend to have higher proportions of serious mental illness, substance use disorders, a lot of social disengagement and difficulty using systems. And so a lot of what we do also involves navigating systems and understanding how to advocate for these folks properly through really discombobulating systems that often are quite broken. That is the work I do, and I do it in New York City, one of the most complex places.
Yeah, great place to be doing it. And I think you actually told me your team was part of writing a paper because you guys do something a little bit more innovative or different than some other cities in that regard.
Right. So I work on a team, an intensive mobile treatment team, which is, it's sort of like a New York City experiment. It is city funded, 100% city funded versus state or federal funding. And I work for an agency called Janian, which is also under the parent agency of CUCS, the Center for Urban Community Services. IMT, intensive mobile treatment, was started first in 2016 in response to a number of kind of really terrible violent crimes that were carried out by people who happen to be homeless and have serious mental illness. And so they were created with the sole purpose of serving this community. And there are 5 different community agencies that run 32 different IMT teams, and Janie and CUCS has 8 of them, of which I'm on one. And we're proud of the way that we do it, and we think we have a unique way that we do it. So we wrote it up. And it's in a paper called Reaching the Unreachable, easily Googleable. It's open source for the purpose of, hoping to spread the word about the work that we're able to accomplish using the kinds of flexible and harm reduction, recovery-oriented practices that we're allowed to given the structure of our program.
It's a really cool program. I remember when I was working back in the Bronx at Jacoby, and we have a lot of patients there that may be living on the streets, may have a lot of addiction, may have a lot of problems like what you're talking to. Not that many of them are on IMTs. A lot more commonly, they would have ACT if they have any sort of psychiatric care that they were really engaged in. And I remember one individual who, while I was there, had been tried to connect it to ACT and really was not going well and was back in the hospital almost every, 3-4 months. And eventually we got him into an IMT. We thought that we were going to have to go to a state hospital, but he didn't really qualify. And I remember how different it felt because I'd seen a lot of ACT teams actually come to the floor. And you say harm reduction, to me, that just came across so perfectly in how they interacted with him and how difficult of a situation they were trying to jump into. But I never saw him after that. And so I don't know what eventually happened. The cycle seemed to be broken. I'm hopeful that maybe that was a good sign. But when you talk about harm reduction, what do you think makes IMT able to do that? Because I think it's something we talk about in medicine in so many different areas too.
Well, harm reduction, in a nutshell, it's about trying to stimulate any kind of change within a person you are meeting with. So on IMT, we call them participants. So helping a participant move just in any direction towards a positive change. How these people end up on our team is that every system that's out there has essentially not worked for them, has failed them, and they've become totally disengaged and unavailable for treatment. And yet we have this duty towards our fellow human beings to try, right? To try to reach out to those people who we all have kind of given up on. And so how can we do that? Well, we have to go through harm reduction, and it's never going to work. What it is that they want to do, that's where we have to go. In training, in psychiatric training, we learn about a clinic or inpatient model of how to treat somebody. It's sort of an algorithm. You do an intake, you figure out what their problem is they're coming to you for, and you figure out whether they're going to get on meds, whether they're going to get some kind of talk therapy, or what's the treatment plan going to be. But in reality, the number of options that we have that we're trained in deeply in our psychiatric training is sort of limited. And it was funny, my very first day on IMT, it was like all of this that went out the window because the folks that I was meeting would not have it. Okay. So then you have to, so what makes harm reduction possible? The flexibility that the team is allowed. The flexibility is there because of a couple different factors, but number one is our funding source. We're 100% grant funded, meaning that each year, the city of New York, the Department of Health and Mental Hygiene, they just give a lump sum to each IMT team. The average is about $1.2 million per year to service 27 participants per team. Now, each team has 9 staff members, and so that's a ratio of 1 to 3. Just as a side note, by contrast, ACT has a ratio of 1 staff member to 9. Their caseload's around 68. So the funding is this lump sum, which means that it's discretionary, that we can do whatever we want with it. What it means is that we're able to meet our overhead and do the things that are practical, flexible, and necessary in the moment for the people we're serving, because they won't have it any other way. They'll just leave. They've left every other system, and if they get a whiff that we're operating in the same way, they'll reject or take off. So, for example, I'm just thinking of the very first patient, I'm calling him patient now, I'm going back into clinical mode, I guess, but the very first participant I met was a 20-something-year-old guy with intellectual disability and schizophrenia who happened to just live at home with his mother and was off meds. Okay, he was off his meds, so we're going there to meet him for the first time and figure some things out. Along the course of getting to know him, this home visit, myself and our social worker said, okay, well, what about the meds? What makes you not able to take them? And he said, well, the Abilify makes me have back pain. So, okay, so do a back exam. Okay, all right. It's looking like there's nothing structurally too wrong, no pain, no particular pain, looks musculoskeletal. Okay, said, okay, well, tell me about what do you do during the day? What do you like? He sits and plays video games all day. Okay, how do you sleep? Shows me where he sleeps. It's a sofa, lies on his left side every night on this worn out old sofa every single night. I said, okay, so before we do anything, do you need a bed? So that day, my first day on IMT, it was about buying him a bed. And sure enough, over a couple weeks, the back pain went away, and eventually he went back on his Abilify. So what are we treating? That's the question. Are we treating schizophrenia? What are we looking to just get somebody on meds, or are we trying to find what the root of a problem is and hear what that person is telling us, take it seriously, and then do what we need to do to reduce the harm that they may or may not be having because of because an illness is untreated or whatever the case may be. But there was no guarantee that getting him a bed would help him get back on meds. But the thing is, we had to take a chance, right? And so I think harm reduction is about trusting the person in front of you, listening to what they're telling you is the problem, and trying with them to figure out a solution that's suitable for them, that they can tolerate in the moment, even if it's not exactly where you as a clinician think you have to go, but kind of together. And can we move in a direction and get a momentum going so that they can at least start to think about a different way of looking at the way that they're living their life and experiencing the things that they're experiencing.
Sounds like it takes so much more creativity than the way training is, and how we like to think in medicine. We like to, put our algorithms out there. We like to say, this is the evidence base. This is first line. This is second line. This is third line. And you're talking about things that are not even any of those options.
That's right. It's really a fun way to practice. And I think that there are very few settings in which you're able to do that with sort of that kind of freedom. And it's actually a shame. It may have been that way in the past, but now there's a lot of rules and regulations that we've got to bind ourselves pretty tightly, and measures, quantifiable measures that we've got to follow. And so really the kind of creativity that's inherent in working with another human being, I think does get lost. And I think it is worthwhile for us to think about how we can recapture that. It's fun. It's fun to think about, hey, what would work for this person?
Yeah, it's an interesting thing, and you talk about just the difference between ACT and what kind of program you have, and even if you take it away from ACT, you talk about how I practice, and I see a lot of patients with insurance, and in that there's certain requirements that go along with that. Like most people have appointments that are around 20 minutes if you're doing some form of therapy, 20 minutes, maybe 30 minutes. If you're not doing therapy, it's usually 10 to 15 minutes, because that's kind of the rules and regulations around what insurance will reimburse, not necessarily what that person in front of me needs, or really what would address what's going on in that moment. And I mean, I see it all the time. There are people that have problems that need much more in-depth, but the incentives don't necessarily give us the kind of flexibility and time to think about those. And they also don't necessarily, if you're looking at the business, how does it get reimbursed? If I'm doing just therapy, that's not nearly as valuable to that clinic as if I'm prescribing medications. And so in all of the areas of medicine, you can see where these kind of incentives, even if they don't necessarily dictate what I have to do, they influence the amount of time I have to carry out what I can carry out. Whereas you're talking about there's this creativity, there's this flexibility. Does that mean from a time standpoint, like, because it's going to take a lot of time to go look at their bed, look at all of these things, find them a bed. Like how do they find the time for you to do that with a patient you have or participant?
It's a really important point, is that the time does have to be there. I think that first visit with this sofa bed business was over 2 hours long, because as you're meeting the participant, you're meeting their family, and you're also trying to do a psychiatric eval in a sort of way, but not necessarily directly. But you're also trying to form a relationship with the human being in front of you who has their own trepidations about this stranger marching into their home. And so I think that physicians are all under a lot of pressure these days because of this privatized insurance that puts these numerical windows for how long you have to treat somebody. For ACT, you have to have a certain number of minutes before it becomes billable, and there's a certain number of visits that are required. And then if you don't meet these kind of benchmarks, then you lose that funding. Mm-hmm. It's a really tough call to make. How much do you push yourself to meet those requirements, or how much do you have to kind of budget a bit? And also, does putting that much in actually have a benefit to this therapeutic relationship? Does it have a benefit to the person? Do they need that? I'm just thinking about the vast variety of ways that our participants are able to engage with us. There was a guy that just last week got finally housed. I've worked on this team almost 5 years, but for the first 2 years of working with him, he lived by the subway stop at 14th Avenue and 14th Street and 7th Avenue. For I think 13 years, he was living outside. And for the first 2 years of our engagement with him, all we could do was bring him a cup of coffee and say hi. And then he would dismiss us. He had psychosis. He couldn't tolerate any more than that. And, eventually it'd get a little better. Like, do you want a sandwich? And he said, yes, would go get it, bring it back and put it in front of him. Over time, now he's housed. He's in permanent, stable housing in a senior residence. But the scale of this is not the scale that we think of in ACT even, which has certain incentives to try to get people discharged from ACT, kind of healed and done with. We just don't think that way in IMT, partially because our participant population is so severe, and so they've been disconnected for so long that we understand that coming back is going to also take a very long time. But if you think about human beings in general, even a garden variety patient who comes into your office for something like just, walking depression, right? They're still going to work or whatever. How long did it take in their life to come to that point where they're depressed and they're actually seeking help for that? It wasn't a month. It wasn't 6 sessions. It wasn't 20 sessions. So I think we have to rethink the timescale of this kind of treatment, and also hopefully the insurance requirements and reimbursements will start to reflect that a bit, but it puts clinicians in a tight spot.
It's interesting. Most of the time we think of where someone's not having to think about insurance is, out of network payments or something in like a concierge type medicine. But you're talking about that model very differently, where the public kind of funds the team, so it provides their kind of salary, their funding, and then they're able to practice that same way without some of the limitations of other types of bureaucracies. And it made me think of, you mentioned them having that first person having a family member, and it made me think of someone recently was telling me in San Francisco that they're trying to address some of the challenges they have by actually funding a team to look for family members and find people that may have connections to some of these people who are living on the streets and connecting them to community members or family members. And I'm wondering if that's something that the IMT team does as well.
We have 27 participants on our team. 2 of them we've reunited with their families. One was also a foreign national, undocumented, and had been estranged from that family for 40 years. The other one had been missing from his family for 20 years. The family was on the west coast of the United States. So we do these things as the need arises, often because the people that we serve have unknown identities, essentially. And so part of our job is to help them to get back their identity documents so that we can get state IDs so that we can apply for benefits for them. The goal is the state ID, and so we've got to work backwards from there because the DMV requires birth certificate, passport, social security, whatever it is to verify who this person is. So in the process of that, we end up finding out these frankly really incredible histories about people. And these family reunions have been really touching and also sometimes surprising in ways that we would never have been able to anticipate. The one, 40 years, her brother was looking for her.
I can't imagine how powerful that would be after 40 years.
It's unbelievable. It's that kind of, what do they call it? The ambiguous loss that people have when someone just goes missing, right? Are they alive? Are they dead? There's no closure with it. And so it is an incredibly powerful thing because families, especially for families with participants who have a psychotic illness, where there may have been a break, not necessarily because something traumatic happened in the family, but because the nature of the psychosis is to be afraid of or suspicious of the family, which is so destructive. But then to be able to bring people back is a powerful benefit of the work that we do.
Which, as you're saying, that kind of reminds me of, I know with the supervisions and times that we talk, how interested you are in psychodynamic psychotherapy. And to me, it's always been an interesting marriage, psychodynamic psychotherapy and this kind of work. And I wonder if you could tell us a little bit about how you see that helping and promoting the kind of work you do in this population.
For a long time, I struggled with that myself because of the seemingly polar opposite natures and of depth psychology versus systems-based practices for people who are disenfranchised. But I think that one just general thought about it is that any further training that we get in understanding human beings is going to be beneficial in any setting that we're working in. So whether I'm working in addictions, whether I'm working on the street, whether I'm working in, a clinic with adolescents, whoever, the psychodynamic psychotherapy training, that comes out anywhere. And, you and I went to Montefiore, did 4 months at Bronx Psychiatric Center, the state hospital. We were doing therapy with people who had been forensically admitted to those hospitals often decades ago. These are another kind of lost population. And I was so shocked as a second year resident to discover that I was able to do psychodynamic psychotherapy with people who had psychotic illnesses. They've committed a crime, been kind of a heinous crime, and they're there for rehabilitation. I was shocked at that. And that really made an impression on me that you never know. You never know where someone can go. And the training that you have, whether it's addictions training, whether it's ACT, acceptance and commitment therapy, or CBT, whatever it is, you bring those skills to the person in front of you, and they're therapeutic for a reason. And so, for example, one of the participants I work with, he requested every other week therapy. And the therapy that he prefers is this kind of looking back into his past. He's had a lot of trauma. and he's able to sort of go towards it, which is remarkable and inspiring. And so if the team is able to do that, we have extremely talented social workers who are also trained in all different modalities of therapy. We will provide that, and these are people who most people think of as lost people in society. I mean, if you're living on the street for 10, 20, 30 years, people won't assume that you can engage in a therapeutic modality like psychodynamic psychotherapy. But I think we have to kind of let go of our biases, and it applies to everybody. Also, I found that training has been very helpful for teams to try to understand what is happening dynamically on teams. The team serves as like an object relations object. We become the family of these people who have essentially lost everyone in their lives. And we become that safe refuge from which, like a spoke on a wheel, where they can come back to the center of that spoke, but they can keep going out and exploring the world because they have a safe place now that they can come back to. And we eventually can become that with the goal of them finding other spokes also to rely on eventually so they can graduate from IMT. But if you've never, ever in your life had an experience where you had a safe place to go back to, you're sure not going to find that just by yourself after you've been homeless for such a long time. You need that. And so this is the kind of principle that I think is valuable for teams to be aware of together. Because then they understand, okay, that's why he calls the on-call number like a million times, because he needs to be reassured that this spoke is still there, this hub for them. And eventually that behavior invariably reduces because they get to know that we're always there. So when a team starts to see themselves in this way psychologically, then it unifies the team. And it also, I think, gives a sense of self-confidence about the work that we do. If we with our therapy training as psychiatrists, if we can bring that as a point of awareness for teams, it helps to frame things for the teams too.
Mm-hmm. Makes me
It's
think
really
of all
fun.
those years with Maddie and our family therapy. And it's something that I mean, you have a lot more team oriented stuff at this point. I'm now kind of off my own private world.
Mm-hmm.
So it's a good point of how we can bring this to the teams and the people that we're working with. And when I hear you talk about Bronx State, I was getting flashbacks to my time there and how true it is, really, the nuggets of training that you learn that help you along the way, even if it's not the exact type of therapy or the type of work you're doing there. I remember working with an individual, very, very protracted paranoia. He was there related to a crime, like you're saying, related to paranoia. And his paranoia never really got that much better. So he's very difficult to engage with. And there was a moment there through, finding an ability to address things psychologically where he trusted me enough to where we actually played basketball together before I finished my 4 months. And it was a very touching moment, but also reinforced all of the ways in which you can work with someone who has paranoia. And it's lessons from that I've taken into other instances where people may not be ready to trust me. I need to figure out how to talk to them and how to address maybe what's underlying that before they're going to trust me.
Absolutely. And I'm just thinking about that patient at Bronx State playing, you guys playing basketball together, and how that must have also been for him such an important moment of someone else participating in his life in that way, especially a clinician, that role. And I, of course, as an IMT psychiatrist who thinks on the time scale of years and even sort of decades of treatment, like what you may have accomplished had you known him for another 2 years, 5 years. Where could he have gone if he had a trusting relationship with a person who was providing him skills for life and also for his well-being that lasted for that length of time? Isn't that such a powerful idea?
Yeah, that's a beautiful idea. The kind of things that may happen long after that we don't know about.
That's right. And it's actually, I'm remembering that time fondly because I think that time challenged so many ideas and had the potential to challenge so many ideas about what we're able to achieve with people and the transformation that can come to people at some point that we may not be able to predict at all. One of our guys that I was matched with, he had been locked up starting at age 16. psychosis, having killed somebody. And he eventually got released in the 60s out of Bronx State, and just the incredible family work that went into that. He was lost in the backwoods for so long, with people just believing that that was it for him. But it took the residency training unit and really the efforts of Maddie, our supervisor, and the belief by our institution at that time of the ability of people to change, and the power of community psychiatry, which is about systems, including family systems, that helped him to reunite with his family and begin to heal the wounds that were there from when he was really just a teenager. So it's powerful what we're able to achieve, and time is so important. We become traumatized with people, and we have to heal with people. That's the idea. The changing and growing and building of trust happens over time. And so we've got to have that time for that to happen. If the treatment for, say, a chronic cancer is lifelong, then can the treatment for intractable depression be lifelong also? And can it be therapy? As therapy and medications, either one alone, are shown to be equally efficacious. So why wouldn't we pay for either?
Therapy.
Right. 20 sessions,
I guess,
10 sessions.
I mean, I can think of the financial reasons why, but
yeah, right.
if we don't jump into that too much, I think I've talked to you about this before. The study that we were talking about when we looked at people who they'll do the medication and they'll do the control arm, which will be a placebo, and they'll have different psychiatrists or different providers. You will have some that seem to have the biggest effect, and that person with placebo was getting better outcomes than the person with medication who may not have been doing so well. And so you really see that any of these interventions can't just be isolated to one thing. And yet we're at a time where people are getting more and more prescriptions just sent online, just filling out forms. More and more we're trying to reduce what is really a powerful ingredient, which is the person providing the care.
And as all of our whole society is moving towards a more virtual landscape, and with AI here and not even on the horizon anymore, there's a lot of talk about, will therapists eventually be replaced by AI and such, and it's a difficult thing to imagine, although I'm a terrible prognosticator of what will succeed technologically, but really it's that human connection, and human beings are so good at being able to tell when someone cares, when someone is being genuine. And it's that alone brings a tremendous amount of healing for people, even if you're not saying exactly the right thing, or even if actually you're saying something they don't want to hear. If the relationship is there, then it can weather the storms of conflict that arise even along the process of treatment. I've had to tell a lot of people a lot of things they didn't want to hear, but as long as we had that therapeutic alliance, then some part of them can recognize and trust underneath it all that you're doing this not for yourself, but really because of your relationship with them. What you've known about them through your interactions. And really, I think IMT, the teams that I work on, we can transmit that in so many different ways. How do we treat people with dignity? How do we promote autonomy and not force things on people on whom probably many things were forced? And I remember this one participant I had, he brought this up. There was a moment where we were walking down the street in the Bronx, and he had this habit of just like throwing his garbage just on the ground. And I just started picking up that garbage. And trust me, there's a lot of garbage in
New York?
the Bronx. Yeah. Well, I would pick up the garbage that he dropped, and I would just put it in the garbage can. And he saw me do that, and he looked so chagrined, like sheepish at himself. But he didn't say anything. Right. And I did notice that after that, he didn't do that anymore. And he brought it up to me much down the road after I had long forgotten about it, just that he couldn't believe I had done that, and that it was something that his mother would have done. I'm not trying to be his mother. I am not his mother. No interest in that. Are there different ways of learning that happen way beyond what we're saying clinically, or the meds, or the formal therapy? There's a lot that happens in the relationship. Maybe your patient saw something in the way that you were playing basketball. Or, people are going to learn from all these things. It's such a human thing that we're doing, this enterprise of psychiatry. And so we have to be aware of that and also be able to offer our humanity to people. I think that as psychiatrists, part of our job must be to know ourselves so much better as full human beings with all the spectrum of human feelings and emotions and impulses and drives. And that helps us become better clinicians as well.
Need to get you in front of an insurance company. Get prior auth for that. But before I recognize, before we have to wrap things up, I want to give you a chance I like to ask if there's something related to psychiatry or addiction that you see as currently underutilized, that you really believe in, either a service or some form of thing that's out there that people maybe aren't using as much as you would like to see.
It's a good question, and I think there are multiple different answers. One of the more concrete things that I can think of is I wish that there could be a paradigm shift around the idea of addiction as being something about a characterological flaw. And that goes beyond just psychiatry, but also into the greater society. I'm just thinking about communities in other places in the world where addiction treatment centers, rehabs and detoxes and things, and methadone clinics are embedded right in the community. So in New York, we've had a lot of NIMBYism, not in my backyard kind of thing. But the idea, I'm just thinking about in Denmark, how the idea is that if someone has committed a crime, the public opinion on that is that somehow they've become separate from society. And so society has to bring them back in. And so substance use clinics, say in Copenhagen, are right there next to, say, something like a Whole Foods or whatever it is, because the idea is they have to be around people and to learn how to be back in society without offending, like to normalize that again for people. And how are they going to do that if they're not around it? So I think the social aspects of recovery and addiction would be so helpful. And I think job programs can go a long way to help with that as well. And then I guess just a very concrete thing is the impact for opioid use disorders. I think Sublocade and now Brixadi have been incredible tools for people to gain the kind of chemical stability within their bodies. I just have seen it change lives for people. And I think there is some degree of resistance to it, but I just wish that resistance might go away because it's a powerful tool.
A lot of great pointers in there, from humanity to Sublocade. And I think the Sublocade thing is really kind of like Suboxone took a long time to get going. I think it's an injection, and it really is a powerful intervention and a powerful tool. And I remember hearing a talk on someone who even was throwing out the question of that being the standard when someone comes in with an opioid overdose from the emergency room or from the hospital, to actually get them onto something like Sublocade at that moment. And I think those kind of discussions are, like you're saying, are really, really good for addressing a lot of these opioid problems we have out in the world.
Yeah, people develop these disorders because over a long period of time, they have become in some way used to chemically feeling a certain way and having different levels of things. You're the addictions specialist. I've worked with some people, but I just found that these have given this stability for people. There's a lot of judgment around it. They're trading one addiction for another. That's a whole other discussion we don't have to get into today, but it just is patently false, because being on methadone or a MOUD it's not an addiction. So that's another whole topic, but it would be great if these tools got used.
Awesome. Well, I thank you for coming onto our show. We're really appreciative, and we look forward to all of you joining on our next one. Thanks a lot.
All right. Kudos to you, Matt. Thanks for having me.
Thank you for listening to this episode of Conversations with AcroPsych. I'm your host, Dr. Matt Campbell. I specialize in psychiatry and addictions. If you have questions about psychiatry or addictions, I host a regular Q&A for therapists, providers, and the general public. You can find more information about us at www.acropsych.com or on all major social media platforms at AcroPsych. We kindly ask you to subscribe to this channel on YouTube or rate us 5 stars on Spotify, since it helps expand our reach and inspire more of our audience.
This episode and all material is purely for general education and not personal medical advice. It does not establish a doctor-patient relationship, and we recommend you working with the appropriate physician or other healthcare provider before applying it to your situation.